All right, let's dive into one of the most high-stakes topics for the NCLEX, atypical antipsychotics. Look, these aren't just any old meds. They are powerful, they are complex, and they are packed with safety risks. Getting a question on these wrong on the exam, well, we don't even want to think about it. So today, our one and only mission is to make you an absolute expert, so you can walk into that exam feeling confident and ready. Let's do this.
Okay, if you only remember one single thing from our entire time together, make it this sentence right here. Seriously, tattoo this on your brain. They spare movement, which means way less of those awful classic movement side effects like tremors and stiffness that the older drugs caused. But they stress metabolism, and that is the huge trade-off. We're talking major risks for weight gain, high blood sugar, and high cholesterol. This trade-off is exactly what the NCLEX is going to test you on over and over again. So here's how we're going to break it all down. We'll start with the fundamentals, then we'll go drug by drug, hitting the biggest safety risk for each one. We'll take a closer look at that metabolic syndrome trap, cover your must-know nursing priorities, and then we'll wrap it all up with a super fast review and a classic NCLEX scenario to make sure it all sticks.
So, why does the NCLEX care so much about these specific drugs? It's simple, really. Patient safety. One little mistake with one of these meds can lead to a disaster, and the NCLEX has to know without a doubt that you are a safe nurse. Mastering these high-alert medications is step one. Let's really nail down the difference here. The older first-gen drugs, they were notorious for causing those extrapyramidal symptoms. We call them EPS. Think about the shuffling walk, the muscle rigidity, the tremors. It was awful. So these newer atypical drugs, they were a total game changer because they have a much lower risk of causing all that. But, and this is the big but, the price we pay is a much, much higher risk of metabolic problems. The upside, though, is that they also work really well on the negative symptoms of schizophrenia, things like social withdrawal or lack of motivation, which the old drugs just couldn't touch. Now, before we get into the individual drugs, you gotta know the risks that apply to the whole family. Think of these as the default settings. Number one, of course, is metabolic syndrome, but you also have to be on high alert for orthostatic hypotension. That's a massive fall risk, right? And then there's the big one, a critical black box warning about using these in elderly patients with dementia. We're definitely coming back to that.
Okay, now for the main event. Let's go through the major players one by one, and for each drug, we are going to laser focus on the single most important, highest yield, you absolutely have to know this for the NCLEX, risk. Let's lock them in.
First up, the big one, Clozapine. This is the heavy hitter of the group, and it comes with some serious warnings. You'll see this used for patients with treatment-resistant schizophrenia, meaning nothing else has worked. And there's a very, very good reason it's not a first-choice drug. The risks are off the charts.
Its number one hallmark, most tested risk is agranulocytosis. And let me be clear, this is a catastrophic drop in your white blood cells. It basically just obliterates the patient's immune system, leaving them completely defenseless against infection. It is so incredibly dangerous that any patient on Clozapine needs regular, mandatory blood tests to check their white blood cell count, specifically their absolute neutrophil count, or ANC. If those counts are low, you stop the drug, period.
And that leads us right to a classic NCLEX question. Your patient is on Clozapine. They call you and say, I have a fever and my throat is sore. What do you do? What is your first priority action? This is a 5-alarm fire. A sore throat isn't just a sore throat here. It's a sign of a potentially deadly infection in a person with no immune system. You hold the next dose and you call that provider immediately. This is a medical emergency.
Next up, let's talk about Risperidone and its cousin, paliperidone. Now, paliperidone is just the active metabolite of risperidone, which is a fancy way of saying they're two peas in a pod. We can group them together because they share the exact same major safety risk.
So what's their hallmark risk? It's hyperprolactinemia. The body is making way too much of the hormone prolactin. For your exam, you just need to connect the drug to the symptoms. You're looking for things like gynecomastia, that's breast development in men, galactorrhea, which is a milky discharge from the nipple, and amenorrhea, which means missed periods in women. See those signs? Think Risperidone. Oh, and a quick safety note for paliperidone. Because it's cleared by the kidneys, you always have to check for kidney disease. They'll need a lower dose.
All right, let's move on to our next dynamic duo, olanzapine and quetiapine. You can think of these as the heavy hitters of the group, but they're heavy in totally different ways. Okay, let's be crystal clear. Olanzapine is, without a doubt, the #1 worst offender for causing metabolic syndrome. We're talking major, significant weight gain, and a super high risk of developing type 2 diabetes. If you get an NCLEX question about a patient who's gained a ton of weight on an antipsychotic, your brain should immediately scream olanzapine. Quetiapine, on the other hand, its claim to fame is sedation. It's extremely sedating, which makes it a huge fall risk, especially in your older patients.
Now let's talk about two drugs that are famous for having very specific rules about how you have to take them. And trust me, forgetting these rules is a super common way to get tripped up on the NCLEX. Okay, first, Ziprasidone. This one has a serious risk of QT prolongation. That means it can mess with the heart's electrical rhythm and lead to a deadly arrhythmia. So you'll need a baseline EKG. But here's the NCLEX pearl. For the drug to even be absorbed properly, it absolutely must be taken with a meal of at least 500 calories. No food, no effect. Then you have Lorazepam, which is great because it has a low risk for metabolic issues. But just like Ziprasidone, it has to be taken with food to work.
All right, next we have aripiprazole, and this one is kind of unique. It works a little differently than the others. Instead of being a full-on dopamine blocker, it's what we call a partial dopamine agonist, and that different mechanism gives it a totally different side effect profile.
So the great news with aripiprazole is that it has a very low risk of causing metabolic syndrome. Awesome, right? The bad news, though, is its hallmark side effect, akathisia. And listen, this is not just being a little fidgety. Akathisia is an intense internal restlessness. Patients describe it as feeling like they are literally crawling out of their own skin. It's incredibly distressing, and it's a huge reason people just stop taking the medication.
Okay, we've talked about it a bunch, but now let's do a deep dive. The metabolic syndrome trap is honestly one of the most important concepts you need to understand for this entire class of drugs. So, what do you, the nurse, actually have to do about it? This is what matters. You need to get baseline numbers and then periodically recheck 4 key things: weight and waist circumference, blood pressure, fasting blood glucose, and a full lipid panel. Catching those little changes early is absolutely the key to preventing long-term disasters like heart disease and diabetes.
And that leads us right into your priority nursing actions and the key patient teaching you have to provide for anyone taking these medications. And here it is, the big one, the black box warning that applies to all atypical antipsychotics. They cause an increased risk of death in elderly patients who have psychosis related to dementia. The NCLEX rule on this is non-negotiable. You do not use these powerful drugs to treat simple confusion or agitation in an elderly patient with dementia. This is a critical, absolute safety rule.
All right, it's crunch time. Let's pull everything we've learned together into a final rapid-fire review. This is the stuff you absolutely need to have burned into your memory on exam day. Okay, let's drill this. Ready? Clozapine, agranulocytosis. Risperidone, hyperprolactinemia. Olanzapine, severe metabolic syndrome. Ziprasidone, QT prolongation. And aripiprazole, akathisia. Say it again. Clozapine, agranulocytosis. Risperidone, hyperprolactinemia. Olanzapine, metabolic syndrome. Ziprasidone, QT prolongation. Aripiprazole, akathisia. Got it? This is how you'll answer these questions in seconds. And now, the moment of truth. Let's put your knowledge to the test with a clinical judgment scenario. This is exactly how the next-gen NCLEX is going to ask you to think like a nurse. Okay, picture this. You're starting your shift. You just got report on 4 patients. Patient A is on Clozapine and is complaining of a new sore throat. Patient B is on olanzapine, and they've gained 5 pounds in the last month. Patient C is on aripiprazole, pacing around the room saying they just can't sit still. And patient D, who is on risperidone, is reporting some new breast tenderness. So, who are you running to see first? Think about it. The weight gain, the restlessness, the breast tenderness. Yes, these are all expected side effects we need to address. But are they immediate life threats? No. But that patient on Clozapine with a sore throat, that could be the first sign of agranulocytosis and deadly septic shock. That is your #1 priority, every single time. It all comes back to airway, breathing, circulation, and life-threatening infection. So let's wrap this up with 3 final golden rules. First, any sign of infection on Clozapine is a medical emergency, always. Second, learn to tell the difference between an acute crisis and a chronic risk. A sore throat is acute, weight gain is chronic. And finally, for every single one of these drugs, always link it back to its main hallmark risk. If you can master these concepts, you are going to be more than ready to handle any question about atypical antipsychotics that the NCLEX can throw at you. You've got this.